In the fourth section of our lecture, we will talk about the non-castrate metastatic disease, testosterone-lowering agents and anti-androgens, and also intermittent androgen deprivation therapy. So the metastatic disease, which is non-castrate, is the state of non-castrate metastatic prostate cancer, includes men with metastasis visible on imaging study and non-castrate level of testosterone, which are more than 150 nanogram per deciliter. So non-castrate metastasis is present on the imaging studies, but these patients are non-castrate along with metastasis because the testosterone levels are still high, about more than 150 nanogram per deciliter. Recurrence after treatment. Symptoms of metastatic disease include pain from osseous spread. Now, once the metastasis occur, there is metastasis, but they are non-castrate because the levels of testosterone are more than 150 nanogram per deciliter. So now the symptoms will be more of metastasis. If it metastasizes to the bone, there is osseous bone, there is pain from the bone and the metastasis of the cancer to the bone. Marrow compromise, myelophthisis. So bone marrow is compromised also. The blood formation from the bone marrow is affected, also known as myelophthisis. Spinal cord compression is also associated with the metastasis, and with the spinal cord compression there will be the signs and symptoms associated with the compression, and depends on the level at which the compression occurs and what are the nerves affected and what area is innervated by those nerves. Coagulopathy is also present because the bone marrow is affected and there is abnormality of red blood cell production and there is abnormality in the platelets, so coagulopathy is present. Standard treatment is deplete lower androgens by medical or surgical means, block androgen binding to androgen receptor with anti-androgens, surgical orchiectomy, gold standard and rarely used, use of hormones on intermittent basis. So that's the standard treatment of the patient, and there we should deplete and lower the level of androgen by medical or surgical means by giving anti-androgen drugs, surgical orchiectomy or the removal of the testicles. Orchiectomy is removal of the testes, and use of hormones on intermittent basis. Testosterone lowering agents, the gonadotropin releasing hormone agonist or antagonist, and these are the leuprolide acetate. These are gonadotropin releasing hormone agonist or antagonist, can be used as a testosterone lowering agent. 17-20 lyase inhibitors, CYP17 inhibitors, estrogens, diethylstilbestrol, they can be used. Progestational agents, they are less efficacious, which have progesterone. Calcium and vitamin D supplements, bisphosphonates and rank lesion inhibitors like denosumab. So all these are the testosterone lowering agents that can be used. These are associated with androgen depletion syndrome. There is decrease in bone density associated with the use of testosterone lowering agents. And also the clinical fractures. When the bone density is decreased, the chance of getting fractures is increased also, and even minor trauma or injuries can lead to the clinical fractures because of the loss of bone density. It's contraindicated. Testosterone lowering agents are contraindicated in men with significant obstructive symptoms present, cancer-related pain, spinal cord compromise. Cancer-related pain is also because of the spread of the cancer or metastasis of the cancer to the bone, and in that condition the bone pain is present, bone is already compromised, further decrease in the bone density and damage to the bone cannot be is not very good. So we should avoid these testosterone lowering agents in patients with cancer related pain. And spinal cord compromise, again the effect will be very harmful. Anti-androgens, against, anti means against androgens. First generation non-steroidal anti-androgens, which are the anti-androgens that can be used. We have flutamide and bicalutamide, nilutamide block legend. Testosterone level increase above baseline. Gynecomastia is a problem which is resolved by tamoxifen. So testosterone level, when it is increased above the baseline, gynecomastia, which is enlargement of the breast tissue in males, can occur, and that's a problem, and that can be treated by the tamoxifen. Positive features are the fewer hot flushes, less muscle wasting, less effect on libido, fewer personality changes, and less bone loss as compared to the drugs used to lower the testosterone level. Anti-androgen drugs have fewer side effects, they have positive aspects. Fewer hot flushes, less wasting of the muscle, less effect on the libido, and less bone loss, and there will be less clinical fractures also, and it can be used in patients who have bone problems, bone pains, and spinal compressions. Anti-androgen plus gonadotropin releasing analog, surgical orchiectomy, triple androgen blockade, which is superior to androgen depletion monotherapies. Intermittent androgen deprivation therapy, use of hormone was a way cells surviving androgen depletion, induce normal differentiation, castration resistant state reduced. Treatment stoppage is done if endogenous testosterone levels rise, symptoms associated with hormone treatment abate, and then prostate specific antigen level increases, multiple cycles of regression and proliferation, and then treatment restarted. So we stop the treatment if endogenous testosterone levels rise, and then we have symptoms associated with hormone treatment. Slowly when they abate, and then once the prostate specific antigen levels increases and multiplication of progression occurs, then we need to start the treatment again. So that's intermittent androgen deprivation therapy. Instead of constant use of androgen deprivation therapy, we can stop, and then we can use it again once the condition again become worse. So that's intermittent androgen deprivation therapy. Outcomes of androgen depletion. The duration of response and survival is inversely proportional to disease extent at the time androgen depletion is first started, whereas degree of prostate-specific antigen decline at 6 months has been shown to be prognostic. So degree of prostate-specific antigen level decrease at 6 months, that's a good prognostic factor. Androgen depletion is curative. Initial response is a period of stability occurs, and then variable period if there is rise in prostate specific antigen and if there is tumor regrowth. Outcome of androgen depletion, again randomized study compared early to late hormone treatment, orchiectomy or gonadotropin releasing hormone analog, patients with locally advanced or asymptomatic metastatic disease, those treated early less likely to progress from MO to M1. Again, the outcomes of the disease, like any disease, in this case of the androgen depletion therapy, is also depend on the different clinical trials performed. Different result of different clinical results shows us whether the treatment is successful or not. And early intervention usually stop the progress from MO to M1 and decrease the spread or metastasis of the disease. That was all about section 4. Thank you for watching sqadia.com.